Welcome to the Deep Dive. Today we're tackling a really high-yield topic, myocarditis, especially if you've got the MSRA coming up.
Absolutely. Heart muscle inflammation. Sounds simple, but there's quite a bit to it.
Exactly. And it presents in, well, all sorts of ways. So our mission today is to really just pull out the core info from our notes, the absolute essentials you need to know, make it stick.
Yeah, cut through the noise, a rapid rundown, basically. Get the key concepts locked in.
Okay, so let's dive straight in then. Myocarditis, if you break down the name.
Myo for muscle, carditis for heart inflammation.
Pretty much tells you what it is. Inflammation of the heart muscle, specifically that middle layer, the myocardium.
And that inflammation, unfortunately, can damage or even kill off heart muscle cells. That's necrosis.
Right, necrosis. And sometimes it spills over, doesn't it? Affects the surrounding sac.
Correct. If the pericardium, that's the sac around the heart, is also inflamed, we call it myopericarditis.
Myopericarditis, got it. And there's a really severe form too.
Fulminant myocarditis, that's the really aggressive kind. Comes on fast, can quickly lead to heart failure. Scary stuff.
Definitely. So what actually triggers this inflammation? What sets it off? Our notes say about half the time.
It's idiopathic, meaning, yeah, we just don't know the cause. Frustrating, but common.
50% idiopathic. Wow. Okay, but for the other half, what are we looking at?
We can kind of group them. You've got infective causes, bugs, basically, bacteria, viruses, fungi, parasites.
Okay, infective.
That non-infective causes, often autoimmune stuff where the body attacks itself. Certain medications can do it too. And then there's a sort of other category.
Right, let's break down the infective ones. Bacteria first.
So the big one to remember bacterial-wise is diphtheria. That's often cited as the most common bacterial cause.
Diphtheria. Okay, key takeaway. What else?
Well, you can also see it with TB, post-streptococcal infections, after strep throat, Lyme disease, even things like Clostridia, Syphilis. Quite a list.
And viruses. I feel like viruses come up a lot with myocarditis.
They really do. Coxsackie B is a major player, especially in places like the US and Western Europe.
Coxsackie B. Got it.
But lots of others too. Think common viruses, EBV, CMV, Adenovirus, Influenza, Ecovirus, HIV, enteroviruses generally, hepatitis, polio.
So a memory tip here might be those viruses causing everyday flu-like symptoms, sometimes they can hit the heart too.
Exactly. Uncommon complication of common viruses. Then you've got fungal causes like Candida, Aspergillus, rarer, but possible.
And parasites.
Yep. Helminths like trichinosis. And protozoa Chagas disease is a really important one.
Chagas. That's the one linked to travel, right? South America.
That's the one. Caused by Trypanosoma cruzi. Definitely ask about travel history. Toxoplasmosis and Leishmania are other protozoal examples.
Okay, that covers infections.
Yeah.
What about the non-infective, the autoimmune side?
Right. So this is where the immune system gets confused and targets the heart muscle. Conditions like SLE, lupus, sarcoidosis, polymyositis, Kawasaki disease, even IBD, inflammatory bowel disease. Giant cell myocarditis is another important one in this group.
So the memory tip could be, if the body's attacking itself elsewhere, the heart might be a target too.
Precisely. And then medications. Sometimes it's a hypersensitivity reaction.
Which drugs are we talking about?
It's quite a range. Some chemo agents like doxorubicin, sulfonamides, cocaine use is a big one.
Cocaine, yeah.
Phenytoin, Herceptin, carbamazepine, spironolactone, methyldopa, even things like lithium, clozapine.
Wow. Okay,
Yeah.
so it reinforces that lots of meds can have rare, serious side effects.
Definitely. And the last category, the other causes. Things like radiation therapy or exposure to heavy metals.
Heavy metals like lead.
Lead, arsenic, copper, iron. Less common, but on the list.
So a huge range of potential triggers. Now let's quickly picture the heart itself, the layers.
Sure. 3 main layers. Inside is the endocardium. Middle layer, the muscle doing the work, is the myocardium. That's our focus. Outside layer is the epicardium.
And it's all wrapped in the pericardium.
Exactly. And in myocarditis, the inflammation in that myocardium can be, well, patchy, we call that focal, or it can be more spread out, diffuse.
And if you actually looked at the tissue, like under a microscope.
You typically see dying heart muscle cells, the myocytes, surrounded by inflammatory cells. That's the hallmark finding.
Got it. So if someone comes in maybe with chest pain, breathlessness, what else are we thinking? What's the differential diagnosis?
Oh, crucial question. Because it can mimic other serious things. Top of the list is ACS, acute coronary syndrome, heart attack.
Right, got to roll that out.
Heart failure itself, PE, pulmonary embolism, pneumonia. They can all present similarly with chest pain or shortness of breath.
Okay. Cardiac, respiratory?
Yeah. And don't forget cardiomyopathy, rheumatic fever, endocarditis, and pericarditis itself. You need to think broadly.
Memory tip. Think broadly about chest pain. Causes heart, lungs.
Exactly.
How common is this, actually? You hear about it.
Yeah, the exact numbers are hard to nail down.
Yeah.
Probably because mild cases might just get labeled as a virus and never diagnosed specifically.
Okay, so it's underdiagnosed.
Likely. It's considered uncommon overall, but it can be very serious, even fatal. We mentioned Coxsackie bee being common here, Chagas in South America.
Right, the geographical links.
And a sobering statistic. Myocarditis is thought to be involved in maybe 10% of all sudden cardiac deaths in people under 40.
10%. Wow. Okay, so paint a picture of the typical patient who walks through the door.
Often it's someone relatively young, say under 50, and they'll often tell you they've just had some sort of viral illness in the last week or two.
A flu-like thing again.
Yeah, that prodromal illness, fever, feeling generally unwell, tired, maybe sore throat, just feeling wiped out.
And always ask about travel.
Absolutely, especially thinking about Chagas or other geographically specific infections.
Beyond feeling generally ill, what specific symptoms point towards the heart?
Chest pain is common, often sharp, stabbing, maybe worse when they lie down or breathe in pleuritic features. Palpitations are frequent too, that racing or skipping feeling, and shortness of breath.
And it can look like a heart attack.
It really can. That's why ruling out ACS is so important.
What might we find when we examine them?
You might see signs of heart failure starting. Fast-breathing tachypnoea, low blood pressure hypotension, raised JVP in the neck.
Okay, signs of the pump struggling.
Exactly. Listening to the heart, the first heart sound might be soft. You might hear extra sounds, an S3 or S4 gallop. If there's myopericarditis, you could hear a pericardial friction rub.
A rub, right, like sandpaper.
Kind of, yeah. And in really mad cases, signs of cardiac tamponade, where fluid is squeezing the heart.
Okay, so suspicion is high. How do we confirm it? What investigations?
Need a logical approach. Start with bloods. FBC might show high white cells. UNEs are standard. Inflammatory markers like CRP.
CRP would be up?
Usually, yeah. ESR might be up too. And crucially, cardiac enzymes. Troponin.
Troponin, key test. Why?
Because it's released when heart muscle cells are damaged or dying. So it's usually elevated early in myocarditis. CKMB can also be raised.
So memory tip. High troponin signals heart muscle injury.
Definitely. You might also send off specific blood tests, serology to look for viruses or bacteria, plus blood cultures if you suspect sepsis.
What about the ECG? What does that show?
It's often, well, non-specific, depends a bit on complications, but common things are sinus tachycardia, just a fast heart rate, non-specific ST segment and T-wave changes.
Like ST depression or elevation, or T-wave inversion.
Yeah, all possible. You can also see heart block, maybe transient AV block, or prolonged QTC interval. Other arrhythmias can pop up too.
And if pericarditis is involved?
Then you might get that classic, widespread, saddle-shaped ST elevation that points more towards pericarditis or myopericarditis.
Okay. What about imaging? Chest x-ray?
Chest x-ray might actually be normal initially.
Oh, right. You mentioned that.
Yeah. Later on, if heart failure develops, you might see an enlarged heart cardiomegaly or signs of fluid in the lungs, pulmonary edema, maybe effusions around the lung or heart.
And an echocardiogram.
Definitely recommended. Again, findings can be nonspecific, but it's really useful. It assesses heart function, how the walls are moving, whether there's a pericardial effusion.
Sixth squeeze.
Essentially, yeah, systolic and diastolic function. Often you see diastolic dysfunction first. Might show a reduced ejection fraction, dilated chambers. Lots of potential clues.
And if there is fluid around the heart, you can test that.
Yes, if there's a significant pericardial effusion, you can do pericardiocentesis and send the fluid for analysis culture, protein, glucose, etc.
Now, the definitive test, the gold standard.
That would be the endomyocardial biopsy, taking a tiny piece of the heart muscle itself.
Sounds invasive.
It is. That's why it's not done routinely. There are risks, and because the inflammation can be patchy, you might miss it limited sensitivity. You need multiple samples, ideally.
So when do you do it?
Usually only if the result would really change your management plan. Like if you strongly suspect giant cell myocarditis where immunosuppression is key.
And what does the biopsy show if it's positive?
It shows those inflammatory cells infiltrating the heart muscle alongside the muscle cell necrosis we talked about.
Any other imaging? MRI?
Cardiac MRI is becoming increasingly useful, yeah. If the patient's stable enough and it's available, it can help differentiate causes and assess the extent of inflammation and damage. Good for non-invasive diagnosis.
Okay, so we've worked it up, maybe got a diagnosis.
Mm.
How do we manage myocarditis?
Number one is treat the underlying cause, if you can identify one. Antibiotics for bacteria, antivirals if appropriate for certain viruses, but often for viruses it's...
Supportive care.
Exactly. Supportive care is the mainstay. Time is often the cure, particularly for viral cases. We can think about management in terms of supportive measures and then, rarely, surgical options.
Let's talk supportive first. What does that involve?
Starts with the basics. ABCDE approach. Make sure they're stable. Be cautious with IV fluids. You want to maintain perfusion, but not overload them if the heart's struggling.
Right. Fluid balance is key.
Treat complications. If they're in heart failure, manage that. If they have arrhythmias, treat those. If there's a big pericardial effusion causing tamponade, it needs draining.
What about steroids or immunosuppressants?
Generally, their benefit isn't proven across the board for myocarditis. They're usually reserved for specific situations like confirmed giant cell myocarditis or maybe certain cases of Chagas disease, otherwise not routine.
And NSAIDs for the inflammation and pain.
Bit controversial. Used cautiously, if at all, especially early on, as there were some concerns in animal models, but often used for associated pericarditis pain.
Okay. Anything else supportive? IVD?
No real evidence for IVG currently. One really important thing, though, avoid strenuous exercise.
Why is that?
Risk of triggering dangerous arrhythmias while the heart is inflamed and recovering. Usually advise against it for several months.
Makes sense. And if they develop heart failure long term?
Standard heart failure management, often including ACE inhibitors. Initially, in acute failure, you might use diuretics, nitrates, maybe NIV.
And the surgical options, when do they come in?
Reserved for the most severe end-stage cases. Heart transplantation is an option if the heart muscle damage is extensive and irreversible.
Transplant. Okay.
Anything else? LVADs, left ventricular assist devices, mechanical pumps that can help the heart, sometimes used as a bridge to transplant or occasionally as long-term therapy itself.
Gotcha. What's the general outlook? If someone gets myocarditis, what's the prognosis?
It's really variable, depends heavily on the cause, how severe it was, how quickly it was treated. But encouragingly, maybe around half of patients recover pretty well, often within a month or so.
That's good to hear. 50% within a month. But there are potential long-term problems, right? Complications.
Right. Yes, definitely. Some people can develop chronic inflammation. Heart failure is a major risk. Dilated cardiomyopathy.
Where the heart becomes enlarged and weakened.
Exactly. That can happen in maybe 10–25% of patients, sometimes years down the line, particularly associated with Chagas disease, but other causes too.
And arrhythmia, as we mentioned.
Yep, arrhythmias remain a risk. And unfortunately, as we said, in some cases, it can be fatal.
Okay, so to quickly recap the key points for recall. Myocarditis. Heart muscle inflammation. Causes, often viral or idiopathic unknown.
Look for that preceding viral illness. Presentation often involves chest pain, breathlessness, maybe signs of heart failure.
Key tests. Troponin is usually up. ECG can show various nonspecific changes or arrhythmias. Echo is useful. Gold standard diagnosis is the endomyocardial biopsy, but it's invasive.
Right. And cardiac MRI is increasingly used. Management is mainly supportive care, treating the cause if possible, managing complications, and avoiding strenuous exercise.
Definitely something to keep on your differential, especially in younger people presenting with those kinds of symptoms after a virus.
Absolutely, don't miss it.
Great stuff. Well, that's our deep dive into myocarditis. Hopefully that's clarified the key points for you.
Yeah, hopefully that helps cement the high-yield facts.
And for more resources to really nail those exams, do check out PassTheMSRA.com.
And freeMSRA.com as well. Lots of useful material there.
Definitely. So until our next deep dive, thanks for listening.